This episode of the Nurse Practitioner Podcast is sponsored by Dakin's Wound Cleanser. When you're treating persistent, hard to heal, or complex wounds, you need a solution you can trust, like Dakin's Wound Cleanser. Just how powerful is it? Dakin's Wound Cleanser has been proven to kill even highly resistant bacteria like MRSA and VRE within only 30 seconds. It's non-cytotoxic, shelf-stable for 2 years, and more cost-effective than other wound cleanser brands. When you need a solution you can count on, ask for Dakin's. This episode is made possible by the JANP Resource Center. Looking to understand how insulin impacts glucose control in real time or strategies to help overcome barriers that healthcare professionals and people with type 2 diabetes encounter when initiating mealtime insulin? Find out answers to these questions and more by visiting our diabetes resources on the JANP Resource Center. A link is provided in the episode notes. In this episode of the Nurse Practitioner Podcast, Dr. Margaret Fitzgerald discusses lessons learned from NPs who have failed the boards. Thanks again for taking the time to chat with us today.
I'm so happy to be able to share this with the listeners.
Now, one of the NPs you spoke to commented that they expected to read the question and quickly recognize the answer. What are your thoughts on this question assumption going into the NP board exam?
What I would say first is do not expect to read any questions and quickly recognize the answer. This can happen at a very low-level fact-oriented question, such as identifying a cranial nerve or something super low-level like that. Very few certification exam questions are written at that level. And in fact, most of the certification exam questions are going to be written at a very high level, very complex. Because remember, this is a test to see if you possess the knowledge base to be a safe entry-level NP, and can you apply that knowledge base. Therefore, the byword is clinical decision-making. You and I have to agree that cranial nerve 1 is the olfactory nerve. Have a nice day, and we're both moving on. If we both know that factoid, it didn't really demonstrate our clinical decision-making, did it? So do not expect to get low-level questions on the boards. Expect you're going to need to analyze and synthesize the content of the question to come up with the right answer.
Thanks for making that distinction regarding board questions. Another NP mentioned that they got through the test fairly quickly and did not think it was that difficult, yet they were stunned when they found out they had failed. Can you please expand on this?
When I counsel people who have failed boards, I would say at least 1/3 will tell that to me. To give you an example, depending on which boards you sit for, the boards have either 150 or 175 questions as a general rule for the majority of boards, and you're given 3 to 3.5 hours to complete. And what that boils down to is, and I'll point out one of the exams that has 150 questions. 150 questions equal to be completed in 180 minutes or 3 hours. So that's to allow you about a minute a question so that you can do that analysis and synthesis part of the role that's so critical to appropriate clinical decision making. And then a nice buffer of about a half an hour to go back and look at any questions you've highlighted. If a person sitting for boards finds themselves scooting through the boards very, very, very quickly, a gigantic red flag should go up. And nearly every test question has what I call a, quote, gotcha answer, or an answer that appears to be really self-evident. And the error is that the test candidate fails to consider all the information presented, analyze and synthesize that information, and fails to deeply consider the purpose of the test question. And that leads the test taker to look at the question and say, oh, this is simple. Answer, next. And an example of that would be something along the following lines. There's a question of let's say, a woman in her late 20s with recurrent migraine. There's no red flag in the question. This isn't an emergency situation. But then it gives 4 interventions for this young woman with migraine. One of them is a triptan. So the person who's not doing the analysis and the synthesis part of the role might go, ooh, migraine, triptan. Those two match. Must be the right answer. When what the examinee failed to appreciate that it was actually a question about prevention of migraine. Triptans are used to treat acute migraine, absolutely, but they're not used to prevent migraine. Therefore, the person who said, "Ooh, that was an easy question, migraine triptan," is thinking at too low a level and is not considering what the true purpose of the question was.
We appreciate you delving into those tricky questions. Another NP said they could not figure out what the question was asking. What can NPs do to better understand questions that may be confusing?
Well, what I have to do is we can't go any further without catching you on the word, quote, tricky question. I hear that a lot from people who both passed and failed boards. They'll say, oh, the questions were so tricky. And I will say to them, no, they're not tricky. They're challenging what the questions are figuring out. Are you able to demonstrate an appropriate knowledge base and the application of that knowledge base to be that safe entry level NP in whatever area you had your concentration of study? So let's get back to the question here. I couldn't figure out what the question was asking. I feel like I need to go back and thank it was either my 4th or 5th grade teacher, who was the person that taught me how to diagram a sentence. And that we had to do this exercise that we had to identify the verb in the question or in a sentence. And what I vividly remember from elementary school is, what does a verb do? A verb directs the action of the sentence. Sometimes identifying the verb in a question can help you figure out the purpose of the question. And then what you have to do is take that step back and say to yourself, is this an assessment question? Is it asking me to gather subjective and objective information so then I could go ahead and come up with a differential diagnosis? Or is this a diagnosis question? Am I given enough information in the question from a subjective objective viewpoint that I can come up with an appropriate diagnosis? Or is this, I'm given the diagnosis, and now what I'm doing is looking at the plan, developing a plan of care? Or could this be an evaluation question where I'm being asked to take a look at response to care? And there is a mnemonic called ADPI: assessment, diagnosis, plan, intervention, and evaluation. And those are the steps in the clinical decision-making process. Those are the steps that we do in order to assess patients safely and effectively. And if you go back to ADPI, you're looking at a question and you're going, what the heck is the purpose of this question? If you remember that mnemonic, ADPI, assess, diagnose, plan, intervene, and evaluate. Look at the question, figure out which part of that clinical decision-making and care process this question is aimed at. You're going to suddenly come up with the right answer.
Thanks for the clarification. This one NP said they did thousands of practice questions and figured that they would be the best way to study for the exam. Why is this not a comprehensive strategy to study for the NP boards?
Practice questions, first of all, are of a wide variety of quality. I've looked at a number of questions that are being distributed as practice questions to get ready for the NP boards. And the questions are written, quite frankly, at too low a level of complexity. In other words, a lot of those questions will be that instant recognition, again, cranial nerve, anatomic landmark, something along those lines, and really not focused on clinical decision making. The other part is what you have to do is keep in mind, one more time, your study should be focused on knowledge building so that you're able to discern the correct answer to all the exam questions. I advocate for using practice questions to confirm, but not try to build your knowledge base. And what you need to do when looking at studying, what I advocate for is work on knowing the how, what, and why of practice. How does a disease form? What is the most likely patient population for this to show up in? What's the appropriate treatment? How will you be able to tell if the person is responding to care? What do you need to do to adjust therapy, or is the person doing much better and stay the course? Why is it that the person can sometimes then fail therapy and you need to go back to the beginning and rethink the diagnosis and the like? So remember, this is a practice of deep, deep, deep inquiry. The majority of questions on the boards will have more than one correct answer, and your job is to figure out what the best answer is for that particular test item and take it from there.
Thanks again for that distinction and sharing what NP should focus on studying. One NP said that more than one answer was applicable to the situation presented and that they were not sure which answer was correct. Can you share any strategies to address questions with seemingly more than one quote-unquote correct answer?
Oh, well, herein lies the rub. You're not looking for just the correct answer. You're looking for the best answer. And that when I'm teaching NP review, and I've been part of a team that's helped more than 180,000 NPs achieve certification, I oftentimes point this out. I'll give the folks in the class a sample item and I'll say, okay, what's the best answer? Because all 4 responses are correct. All 4. and then what you have to do is look at the question, not hit the panic button saying, what do you mean at least 2 of these items, 2 of these answers here are correct? What you have to do is choose the response most specific to the given situation. Sometimes the questions that relate to presentation of disease have more than one applicable answer. What you want to do is go with the most common presentation of the condition, not the least common. For example, an adult with bacterial meningitis can have nuchal rigidity and papilledema. Nuchal rigidity, neck stiffness, papilledema, bulging of the optic disc, usually indicative of increased intracranial pressure. And those 2, since they're both technically right, would be the best answer? Well, nuchal rigidity or neck stiffness will be seen in the majority of adults with the diagnosis. Papilledema seen much less commonly. For those of you sitting for the family exam, if you have a pediatric developmental question, very often these have more than one correct response. For example, a healthy 4.5-month-old infant is expected to roll stomach to back and smile. However, smiling is a developmental milestone that's achieved by or even before 2 months. Well, the rolling over is typically not seen until the baby is 4 months old. Therefore, 4 months old is a better answer if you are being asked that you're evaluating a baby who can roll stomach to back and smile. 4 months old is a much better answer than 2 months old. I'll throw one more in here. We all know, because we've been RNs, is that with an asthma flare, there can be intercostal retraction. And remember, I'm talking about asthma flare here. However, that is only seen in extremis with an asthma flare. It's an uncommon finding in asthma flare, whereas elevated respiratory rate or expiratory wheezing will be seen in the majority of asthma flares. So if you had a question that asked about findings in an asthma flare, and one was intercostal retraction, and the other was expiratory wheeze. Expiratory wheeze is a much better answer because the majority of people with asthma flare will have that.
Looking for the best answer. Got it. Thanks for sharing those examples. Another NP said that they currently practice as an RN in an acute care setting and that the scenarios and treatment options presented in the questions were quite different from what they were accustomed to seeing in their current clinical setting and that they had a hard time choosing the best answer. Can you share any tips or advice for unfamiliar situational questions?
Particularly for the acute care RN who is transitioning to one of the primary care roles, like family, adult gero primary care, even women's health. It is a tremendous role transition because what you're doing is you're shifting from inpatient acute care to outpatient, more primary care oriented. Now, as a very, very proud primary care provider who was a critical care nurse for 16 years before I became a nurse practitioner, I am not saying that leaving the acute care setting and going to primary care means that the work is less demanding in primary care or it's, quote, simpler than in the acute care setting. Not at all. However, on the other hand, the way we treat pneumonia out in the community is quite a bit different than the way you treat pneumonia in the person who's sick enough to be admitted to the acute care hospital. Most new NPs are experienced RNs, and of course, you take that experience with you to the NP certification exam. If you've been practicing in the acute care setting, you are the expert in the worst case scenario. And I'll give you an example here on community-acquired pneumonia. For every one person admitted to the medical floor with community-acquired pneumonia, somewhere between 50 and 100 people are treated in the outpatient setting for the pneumonia. Okay, that's how unbelievable the difference in the ratio. In other words, far less than 2% of all adults with community-acquired pneumonia get admitted to the hospital for it. Who did you see on the medical floor? Who did you see in the ICU? The sickest of the sickest of the sick. And if you start thinking like an NP with every patient you encounter in your RN role, this is going to be really, really helpful. So I'm going to give you an example of one of the last people I saw in my practice with community-acquired pneumonia. The person's very well connected with our practice, primary care patient. I was working, she's been my patient for many, many, many years. She was 2 to 3 days into increased cough, fever, worsening difficulty breathing. In other words, a classic pneumonia. Woman in her 80s with many chronic health problems. I was able to intervene early on, get her on the right antimicrobial, do 2-day follow-up on her, evaluate her response to care, and she did very well. She also had the benefit of tremendous family support, which of course is really important, so that she was able to be managed at home. And I was also able to say that I knew if she got worse, her family would scoop her up and bring her to the hospital immediately. I would be willing to bet when you saw the last patient you admitted with community-acquired pneumonia to the medical floor, that person had been sick for a week, 10 days. In other words, very often these are people who get treated much further into the disease process and therefore now have, shall we say, the worst case scenario. That's what you're accustomed to seeing on the medical floor, in the ICU, I dare say even in the emergency room. What you'll be tested on, if you're being tested in one of the primary care roles, is going to be outpatient therapy, where people are less sick when they're initially presenting.
Thanks for those insights. Another NP claimed that they have hard test anxiety and have always been a poor test taker. Can you provide us with some advice for folks who deal with anxiety during exams?
I want you to take a big step back from labeling yourself as having hard test anxiety and always being a poor test taker. Here's the reality. You're a nurse practitioner or about ready to graduate from NP school. You have had at minimum, bare minimum, 6 years of post-high school education. Because at bare minimum, you've got a bachelor's degree and a master's degree. Some of you have 7 to 8 years of post-high school education. Plus, let me point out to you, you graduated from high school. So you've got a lot of education under your belt. If you were truly a horrible test taker, how did you get to a point today where you're eligible to sit for the NP boards? You have taken SAT, GREs, countless other tests in your undergraduate and graduate education. You passed NCLEX. You're probably certified in something at the RN level. Were any of these tests pleasant? No. However, anxiety is an anticipated part of sitting for a high stakes exam. It simply is. And if somebody said to you when you were in 4th grade and you didn't do well on a fill in the blank test, oh, I think you've got test anxiety, that person unfortunately handed you a bag of rocks to walk around with that you keep carrying as you go through your education. Put down the bag of rocks, take a look in the mirror, and admire what you have accomplished educationally. And there's a lot to admire here, tremendous amount to admire here. Sometimes we lose track of the fact that anxiety is a normal part of test taking. And rather than allowing the anxiety to overwhelm you, remember what the anxiety does. It boosts up your norepinephrine levels, which are all about focus. So you could do one thing or the other during the exam. Let the elevated levels of norepinephrine make you feel jittery, make you feel like your heart rate's up a little bit, or you could say to yourself, my norepinephrine levels are up. This is good. This is going to give me focus, and use it in that way. My major test taking tip here is the best cure for test anxiety is increasing your knowledge base. And I can't say that enough. Be able to walk into that exam with a great knowledge base, focused on ADPI and that how, what, and why of practice. And that's going to go a long, long way to relieving test anxiety.
Sometimes it really does just come down to believing in yourself, huh?
Exactly. And what I do need to say to people who are graduating from NP programs right now is, remember, you went to all or nearly all of your NP program during a global pandemic. No one's ever done that before. And you were a group of people who suffered with more chopped up clinical rotations than is typical, with some challenges, with some of you switched from brick and mortar learning to online learning. And to boot, the RN who does not work or doesn't practice at the RN level during their NP program is almost like a unicorn. I can't remember the last time I met an NP student who was an RN but not practicing at the RN level. You have been to school under very difficult circumstances because you not only were studying under difficult circumstances, but you were also practicing at the RN level, taking care of people who were horrifically ill with COVID-19 and being exposed to a virus that you know and I know could have killed any one of us. Thankfully, it didn't. Give yourself some grace. Cut yourself some slack. Give yourself 3 months, 6 months if you need to get ready for your boards and work on your knowledge base. And that's going to do a tremendous amount of work to relieving your anxiety.
Thanks again for the encouragement. Finally, this NP said that they graduated from a highly competitive NP program with a solid GPA and felt they were well prepared for the test, but still failed. Is there any advice or words of encouragement you can provide for folks who are not expecting to fail the NP board exam?
I hear this fairly often saying, I graduated from one of those programs. It's always in the top 20, the top whatever of NP programs in the country. How the heck could I have failed boards? Your program does help prepare you for practice in boards. However, you need to anticipate additional study. Now, I teach NP review, so obviously I have a bias here that NP review is really helpful to allow you to yank this all together. At the same time, it's your job to develop that plan of study that works on building your knowledge base, honing your clinical decision-making skills, and then that's how you're going to be best able to pass the boards.
Do you have any final thoughts you'd like to share?
I have a few final thoughts here. And one of them is a hop off from the comment I made earlier about the acute care treatment of patients, quite a bit different than the outpatient treatment of patients. And remember that as you're changing location of care, and this would apply to a person sitting for the acute care exam who's now given a question on outpatient therapy, or this could apply to the person who is thinking like the RN and now is in the outpatient setting with nurse practitioner. Remember some of the basics with prescribing on this, and that inpatient care, outpatient care, two very, very, very different creatures, if you will. And you need to focus your study on what will show up on the boards the most often. Think more oral medications than parenteral medications. Think medications in drug classes rather than individual agents. There are a lot of considerations that you have to take in mind. Also, last but certainly not least, your RN role is very focused on evaluation. In other words, taking a look at a patient who's already had a diagnosis, who has already been treated, and ensuring that person is responding to care. As the nurse practitioner, we certainly do that evaluation process, but now we are also the assessors gathering that subjective all objective information. We're now the people who are coming up with the differential diagnosis. We are now the people who are writing for the plan of care, and we're doing evaluation or response to care. Keep in mind all those parts of the clinical decision-making process. And one last comment. The boards are not an artificial barrier between you and your NP license. The boards are rather a validated exam for you to demonstrate your competency to practice. People who failed boards have not demonstrated the ability to be a safe entry-level NP. People who have passed boards have gone through that milestone and demonstrated they will be safe entry-level NP. You can learn a lot, even as you're getting ready for boards, from people who have failed boards. The tips I'm giving you have come largely from comments made to me by people who failed boards, who said, I never want anyone else to suffer like I have through failing boards. Share these. And what we need to do then is thank our colleagues who were so candid with their comments, so that you learn from this, and even before you sit for boards, you're going to know what can be the difficult situations to encounter on the NP boards.
Dr. Fitzgerald, thanks as always for your time and exceptional advice. We look forward to having you back on the Nurse Practitioner Podcast in the future.
And I greatly look forward to the honor and the privilege of sharing with you in the future.
Thanks so much. For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes and Spotify, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at the Nurse Practitioner Journal, and on Twitter at TNPJ_journal. Thanks for listening. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks again for listening.